I'm Dr. Reuben Sloan, and welcome to our next podcast, Back Talk. We're going to be talking about spinal injections and other injections that physiatrists and other spine doctors do.
Hi, I'm Dr. Michele Perez, joining Reuben Sloan today on this episode of Back Talk.
All right, so when a patient comes in to see you, a lot of times they come in wanting an injection, which seems kind of funny because people don't like needles.
Right.
But I know that happens to me all the time. So what do you do? How do you approach that? What's your protocol, so to speak, when it comes to spinal injections?
And discussing it with them and like sort of how to present it to them.
Yes.
Yeah. So you're right. Sometimes, and they have just been told about injections, or they have a friend who had an injection or something like that. Or they've even had injections in the past, but they don't really know what they've had done. So my approach usually is I categorize them for them. I say, okay, so there's different kinds of injections that we do. Some involve medications, some don't. Some are more nerve blocks, and some are just interventional procedures where we're not using any steroids. So I usually will break it down into ones we can do in the office, tell them that. So steroids are anti-inflammatory medications that we use in most of our injections to reduce inflammation. We can put that in the knees. We can put that in the shoulders. In our case, in the office, we're usually putting it in like a hip bursa or in the muscles of the spine. So we call those trigger point injections. So they just mean they're going in the muscles of the spine, and we're injecting a combination of lidocaine and steroids. And some people only use lidocaine or anesthetics. There's a different school of thought on that.
And would you do that right when they come in, or are there other reasons why you would hold on that?
It depends. Sometimes I don't offer it at all. I usually offer it if their pain is more localized to a small region of their body, their shoulder blade, their neck, their lower back. If they have very global pain, we see patients come in all the time with horrific neck pain all the way down their arm. We know they have a pinched nerve. And a cortisone injection like that's really not going to do a whole lot of good, in my opinion. So I don't usually offer it. Sometimes I don't offer it at all. Sometimes I test the waters a little bit to see if I'll sort of present it as, sometimes I can give you a little bit of immediate relief until we can get you started on these other things. So I can give you an injection today if you'd like, and I explain that. And sometimes they don't want it, and sometimes they do. So I just I like to tell patients I'm laying out all the options for you, telling you the good, the pros and the cons, and kind of letting you decide what you feel comfortable with.
And what about epidurals? So a lot of people come into my office thinking that all spinal injections are epidurals, and obviously that's not the case.
Right.
So how do you approach that subject?
Yeah. So then I sort of go into, then we have our procedures that we do outside of the office, which we would consider interventional procedures. And epidurals are just one type of procedure we do in the spine. Epidurals are also steroid injections, but they're being targeted and the medication is being delivered directly into the spine, whether it's the neck, the mid-back, or the lower back.
And how is that? How is it delivered directly into?
Via needles and using X-ray, or what we call fluoroscopic guidance. So you don't want to put an injection in a spine without some sort of imaging. And in our case, we use X-ray. So patients come to an outpatient center and we can visualize their spine and inject that medication, number one, precisely, number two, safely, and number three, in a sterile environment. So those are the main reasons. And that's because you can't inject an epidural properly blindly. What is the statistic? 30% of the time when they did blind epidurals in the past, you missed.
Right.
So
historically, epidurals were done without X-ray guidance.
Right.
Think of women having children for childbirth. They're not done with X-ray guidance. So a lot of doctors used to do them without any guidance, without any fluoroscopic or X-ray guidance. And that's where the rule of three comes in, because a lot of people would come in and say, I want to get 3 epidurals. Can you sign me up for 3? And that's where we believe the rule of 3 came in, because you had a 33% chance of getting it right. And if you did it 3 times, you're going to get it once, at least once.
Right.
So that's where the rule of 3 comes out. And now with the advent of X-ray guidance, it's been around for almost a quarter of a century now, we can see where the needle goes.
Right.
We can inject contrast dye in, assuming they don't have any contrast allergies, and we can see the dye going in, and we can make sure the medicine's going to go where we want it to go and not astray before we inject the real stuff in. So it makes the injection incredibly safe.
Right.
But what about other injections that people think are epidurals but aren't, that are done outside of the office?
So the last thing I wanted to say about the epidurals is I really make a point of educating patients that epidurals do best for extremity pain.
Correct.
When people have nerve pain down their arm or their legs, or pinched nerves, or herniated discs, or a variety of different conditions, that epidurals historically were used for everything. It was just thrown at every single diagnosis that walked in the door.
It was a wastebasket, right?
Now we're very particular about why, when, and how we use epidurals. So if patients come in with what we call axial pain in their spine, just in the axis of the spine, epidurals are not the first choice. They can be used. I've had times when I did use them, but that's not the first choice.
So what would you do as your first choice?
For axial pain?
So for pain that's not going down the leg. So
Right.
I've had a lot of people come in and say, I have sciatica, and they just have pain in their back.
Right.
Which is not technically sciatica, it's pain down the leg.
That's a great thing to define, because I hear that word every day in my office. I hear sciatica. Sciatica is actually defined as pain down the leg.
Correct.
So sciatica is not pain in the back or buttock area, which is where a lot of people feel like their pain is. So sciatica is really what we use that word for, is pain down the leg, because it's the sciatic nerve that often gets compressed.
And almost, if not always, down into the foot. So all the way down the leg into the bottom of the foot or the outside of the foot.
Sure.
So what do you do for injections that are in the back that aren't epidurals?
Right. So I like to break it down into, we know that patients can have, we usually say 4 different types of pain. They can have pain in the bone, they can have pain in their joints of their back, the discs of their back, or the nerves. That's where the sciatica, the pain down the extremities, comes from. The axial pain can usually come from bone pain, joint pain, or disc pain. Figuring that out as part of the diagnostic workup that you and I do, x-rays, MRIs, that sort of thing, physical exam. Bone pain's very different. That's fractures, or in some cases, something bad like a cancer. We don't use injections for those things typically.
Right.
I guess we can talk about fractures, but the other things we do for axial pain is usually facet joint injections, which are injections of steroids into the joints of the spine, called the facet joints. It's where the bones articulate to one another. Historically, we used to do a lot of steroid injections into those joints, we use them for both diagnostic and therapeutic purposes, but we've sort of been banned, so to speak, from doing that by insurance companies now. They're still very useful, but we don't get a choice to do them in most cases any longer.
Right. Do you know why we were banned?
I don't know if I know
So it's not just we. So what happened?
No, not we as in just resurgence.
Right. So what happened was the injections, interventional spine injections historically with the X-ray guidance have commanded large dollar amounts. And we're not talking huge dollar amounts, but compared to stuff in the office. So doctors who did not have proper training would go to weekend courses and would learn how to do spinal injections after spending a weekend with a proctor. And then they were on Monday morning starting to do spinal injections with no training. Mm-hmm. And the insurance company saw an explosion of the charges for facet injections. And they were not doing facet injections. They were doing deep trigger point or superficial injections. Mm-hmm. And they put a stop to it. Mm-hmm. And what they did instead, which I'm sure you're going to talk about, medial branch blocks, because those require extensive, usually fellowship training, because you have to target very, very specific nerves deep in the back. And that eliminated the fly-by-night people who were weekend warriors that were learning how to do these injections and were not really giving people quality care. So that's why we got banned.
Right.
We didn't really get banned. The insurance companies just wanted to put an end to the fly-by-night, the overuse, the abuse, really, of people who shouldn't be getting, shouldn't be using spinal injections in their armamentarium because they're not skilled in doing them.
Sure. And I still use them when I can, especially in patients who have very inflamed facet joints. We'll see patients, with these large effusions, which is a buildup of fluid in the joint, or synovial cysts. We see that quite a bit. So they still have a great bit of use, and they're very effective.
We can still do them, just insurance companies won't cover them for the most part. I've had patients that came back that had great responses to facet injections, years of relief, and wanted them. And I explained to that the insurance companies changed the rules, and and they would just pay out of pocket because they were so effective, and they gave them so many years of relief.
Yeah, because steroids work. So.
Steroids work beautifully. Yeah.
So now the alternative to that, which we use liberally in the spine these days, and I do have great results with it. So now we do a process called medial branch blocks and radiofrequency ablation, which is still targeting the same structure, the facet joint, but now we're targeting the nerve bundle that carries the pain information from that joint to the brain. So we're blocking that, and then we're blocking it as a diagnostic tool to confirm that those joints are in fact the source of pain, because we don't always know by diagnostic test and by physical exam. That's sort of the last piece of the puzzle. And then we do a very common treatment called radiofrequency ablation, where we use radiofrequency waves to cauterize or burn that nerve bundle, thereby killing it temporarily until it regenerates over a period of a year or two. So it's a great treatment because it is very long-lasting. I mean, that's been proven. It is very long-lasting. And some facet injections can be very short-lived. And I have seen patients get relief from ablations for 5 years and longer. So it's a great tool. I wish we had a little bit more leeway to choose between the two. But that's what we're mostly focusing on now.
So I get asked this all the time. So, doctor, if you're going to burn a nerve, isn't that bad? How am I going to know if I'm feeling pain?
Right. Common question. So luckily, our spine is an incredibly rich network of nerves. I always explain it to patients that burning that nerve is like losing a twig on a tree. You still have the trunk of the tree, which is the spinal cord. Obviously, we need that. The big branches, which are our spinal nerves or nerve roots, which control the muscular movements in our arms and the feelings in our arms and legs and in our extremities. The sensation comes from those nerve roots. These branches are simply sensory nerves only that only take information from that joint and that joint only. So we can live without it, still function well. We're reducing pain, and therefore patients actually function better because they're not limited by pain. They actually get better range of motion because they don't have pain. They're not so limited. So you have this whole other network of nerves, the spinal nerve roots, the nerves to the muscles, the nerves to the bones, the nerves to the disc that are all still fully intact. So there's no functional harm to those patients. And once they find out that that's the case and they have the relief and they function completely normally, they're amazed.
Right.
Yeah.
So I tell the patients basically the same thing. I tell them it's a branch off of a branch off of a branch. So it's a terminal branch. But I like your analogy about the tree trunks and the tree branches and then, a twig.
Yeah.
So I want to use that. Thank you.
You're welcome. Yeah. It's a great metaphor.
Any other spinal injections that we haven't talked about that you use?
So some steroid injections we often do in the sacroiliac joint. Sacroiliac joint's a huge, important, not a huge joint, but hugely important joint, and that it is a joint in the pelvis of our body, which lives right under, the sacrum is connected to the lumbar spine, that bone is connected to our pelvic bones in the back side, and they form two sacroiliac joints, one on the right and one on the left, and it's a common source of back pain. Hard to diagnose, as we know. It takes a very skilled physical exam. Sometimes testing doesn't even, or diagnostic testing doesn't even confirm it. So we often inject those joints for pain relief and diagnostic reasons as well. So hip joints, of course, huge part of our practice. People with arthritic hips. What else am I missing? Yeah. And then there's another procedure that I started doing recently, but I'm going to let you finish. There's another procedure I started doing recently that I wasn't doing up until 6 months ago.
Which one is that?
The basivertebral nerve ablation.
Okay, yeah.
It's the brand name of it is Intercept. So there's been some, I guess, more information over the last decade about we're starting to understand more about what we used to call discogenic pain. We know a lot of back pain comes from the disc itself. The disc degenerates. It can herniate. Mostly degeneration is the reason for chronic low back pain, or one of the sources of chronic low back pain. So if we've gone through a protocol of treating the patients with pharmacologic agents, therapy, manual therapy, all the things, sometimes chiropractic, multiple injections, you and I will try many injections. And if we don't get any relief, sometimes the source of the pain is the bone that lives next to the disc. So we call those in plates, and they become inflamed, chronically inflamed. And there is now a procedure where we can use radiofrequency waves the same manner that we do for the facets and use that inside the end plates and cauterize what's called the basivertebral nerve, and taking away the sensation from those end plates, the chronic bony pain that patients get from degenerative disc disease. A little bit more invasive than facet radiofrequency ablation because you have to make a tunnel into the vertebral body to get the probe there. But there seems to be huge success with this new procedure. So it's something relatively new in my practice that I've started doing.
So same idea as RFA for the facets, except the target's different.
Correct.
And the same thing applies where it's a branch off of a branch off of a branch. So the only thing you're losing are the nerves that are causing pain in that end plate.
Pain fibers is all. Yep. And that nerve is not myelinated. So myelin is the coating over our nerves that helps our nerves transmit very rapidly through the body. And without myelin, they don't transmit very well at all. And because that nerve is not myelinated, it does not regenerate easily or not at all in some cases.
Good.
So it's very long lasting.
So it's curative usually.
It can be.
That's great.
Yeah, it's new to my practice, so I don't have a great volume to talk about yet, but I see a lot. It's exciting to do because it's something else. I felt there was a hole where I couldn't offer something else because then those patients either had to go to surgery or live with it, and that was driving me bananas.
Right. And now we have something to offer them.
So, yeah.
So back to the hip and the SI. So in my practice, it's the one entity that people have come to see me where they've had multiple encounters over the years with different doctors and nobody bothered to look at their hip joint. And I'll see them walk and I'll think, this could be their hip. I'll get an x-ray and their hip looks horrible.
Right.
And their back pain, their buttock pain was coming from their hip. So a lot of people forget about how important the hip joint is for causing back pain.
Yes.
And then the SI joint, also, people forget about that joint, sadly, and it's such, when it is responsible for pain and we block it and people get relief, it is life-changing for them.
And it's now, I think the numbers that we often learn about are at least 25% of chronic back pain could be the sacroiliac joint.
Right.
And then you could throw the hip in there too. But sometimes that has a little bit different symptoms that we can catch on to a little bit more quickly because those patients often have groin and thigh pain. And so you can catch it a little bit more easily, but it is missed a lot. You're right.
So the bottom line is we have a lot to offer patients that's non-surgical.
Oh, yeah.
For people that have had back pain either for a day or for a week or for a year or for decades.
And then I think the question that I get asked a ton and you get asked is how long are these going to last? And that's the million-dollar question. Right. We don't know because we have to get the proper diagnosis, and that injection helps us confirm that we're on the right track, or I always say barking up the right tree. And if that injection works, then how long does it work will kind of dictate what our next steps are. Because those injections, all these injections can be repeated. And if they need to be repeated over a lifetime, that's okay. Some patients will live a lifetime and just manage their back problems or cervical or spine problems with injections and procedures, and they don't have to go on to surgery. So I tell them, I don't know. But once we figure that out, then we'll come up with a plan long term, and we repeat these, try something else, flip-flop back and forth, or you start to get less of a return on your investment, and we come up with plan B, which is surgery.
So is there a limit as to how many injections somebody can have?
Not in a lifetime, but we do have to follow some guidelines by insurance companies of how many we can do in a 12-month period or a year. Right. And typically that number is 4 over a 12-month period.
So the
steroid injections, I should specify,
right.
And the ablations we can do every 6 months.
So we looked at this, and it's actually the limit for steroid injections is 6 per year. All of the spine societies have looked at this, but of course the insurance companies ratchet it down to 4 to save money.
Right.
So there's an inherent safety valve with it only being limited to 4. And it's pretty rare that somebody needs more than 4 anyways, at least not in the same area. For me, the spinal injections are a means to an end. Yes, they can be pain relieving and life changing, but I reinforce how important physical therapy is.
Right.
And just because I got your pain under control doesn't mean we're done.
Right.
We need to send you back to PT, and now there's a whole slew of exercises the therapist might be able to do with you that he or she could not even attempt before. And those exercises are going to be maintenance. They're going to keep you off of my injection table.
Right.
And if we need to inject you again, then of course we will, but it doesn't mean we have to.
And don't you find that patients seem to get super excited when you explain that to them? Like, okay, I understand you're in so much pain right now. You can barely function. We'll do this injection, then we'll get some physical therapy started. Because they're so, sometimes I think they're fearful that I'm going to go to physical therapy. You want me to do what?
Right.
And so sometimes, even though I know we keep talking about insurance, but they put up barricades sometimes, and you and I know that they would probably do a lot better if we got that pain level down and then sent them to physical therapy. Physical therapy can't always benefit people right off the bat. We know that, but we're sometimes limited by with the things we can do.
Yeah, and taking that subject a little bit further, so I've had patients tell me or ask me so frequently, how much is this injection going to hurt? And it's depending on the person and their pain tolerance and what's going on. But I tell them not as much as you imagine it to be. And I can't tell you how many times, and I'm sure this happens to you too, where patients are like, that's it?
Right.
You're done? Really?
Absolutely.
The entire injection's done. I go, yes, we're done.
I thought you were just numbing me up.
Right.
It's my favorite. I love that. Yeah.
Right. So injections are not.
Because when you're taught properly and you cause little trauma.
Correct.
And you use
X-ray
appropriate
guidance.
amounts of anesthetic and you use
Correct.
X-ray guidance and you're not poking around.
And you talk to your patients through the process.
You talk to them.
Unless they don't want to be. Some patients don't want to hear, and I
Right.
respect that when that happens.
Right.
But I talk them through the process, and they're pleasantly surprised at how easy it was.
Yeah, I agree. And another thing we should probably talk about is sometimes patients will come into the practice and they've had injections done at other places where they were quote unquote put to sleep.
Correct.
Now, we know that that practice is not recommended. Patients should not be under general anesthesia for these types of injections because we do need some amount of feedback. Because what if you get a little close to something and they start to feel a little pain down their leg? You want to make sure you stay away from that nerve root. That sounds really horrible and unpleasant, but it's important. So I explain to patients, most of these can be done without any sedation at all, just local anesthesia. But some surgical centers are able to provide a little bit of sedation for just for anxiety relief.
Yeah, so what we use oral sedatives that dissolve in their tongue, so they dissolve quickly and they act quickly. But the person is still awake.
Correct.
They're just calmer.
We call it conscious sedation.
Conscious sedation.
Right.
And they're less stressed so that they can be aware because we can't see the nerve.
Right.
We know where it's supposed to be.
Right.
And we don't go there, but sometimes the nerve is displaced because of circumstances unique to their situation, anatomical changes.
Right.
And we need to know that. So we don't want a person to be asleep. It's more detrimental for them to be asleep than for them to be awake but calm.
Right. Partially, too, if you're asleep, you have no muscle tone. And we need a little bit of muscle tone to literally keep people in the right place on the table. If their head's lolling around, that won't work for us. We need patients fairly still. Not, they're scared if they even take a deep breath, it's going to mess them up, but it doesn't. We should also probably point out that when we're doing these injections under X-ray guidance, we cannot actually see the disc herniation or the nerve or the thing we're targeting. The reason for the X-rays, we know what's wrong. We're using the fluoroscopic guidance to target that specific level of the spine and use the anatomic landmarks of the skeleton. So we can't see the thing we're injecting. We just know we're going in the right place because we're using our other test.
Our MRIs or our CT scans, right?
Correct.
So we know what we're up against, but we cannot see it on the actual X-ray.
Right.
The X-ray is only there for guidance purposes
Right.
to make sure the medicine goes where we want it to go and not astray.
Right.
Exactly.
So any other injections that you do that we didn't talk about?
No, I do a lot of hip injections. It's just part of my practice. It's just the way things, fell into place. And they're the most therapeutic thing I do. It's really astounding at how much significant relief they get and for how long. And that's the one where I always get, that's it. I can't believe you're already done.
And how much relief they get of their back pain, which is
back pain, buttock
always
pain,
surprising.
Right? Groin pain, thigh pain, knee pain even. It's really astounding.
It is, yeah. But, So are the injections, would you say that's a huge part of all of our practices? I mean, for me, it is.
It's 40% of what I do.
Yeah.
Yes, almost half.
Right.
I do some other weird stuff. It's niche. I've blocked psoas muscles, which is the deep muscle. It's the tenderloin muscle in us. That's deep in, and it's a special person that needs that injection done. But we all have these skills, and we know how to do it when it calls for that.
Injections,
Piriformis injections.
For pain in the buttock area. But I think what we balance out well at Resurgence is that we don't just focus on injections, because these folks, we're seeing them first, making a proper diagnosis, using those injections to enhance our diagnosis and get them well, not just doing injections just to do injections.
Correct.
Because that is where the abuse and overuse comes in. So
correct.
Yeah. All right.
Thank you.
Yeah. Thank you.
All right. That wraps up our podcast on spinal injections. Thank you.
Thank you.